Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind invitation of PAIRS, and my nightmare is to give a presentation after the slides of Professor Mohammadi and presented by Eric Verhoeven. So this is my worst nightmare. Anyway, I will speak about something which I like, which is choosing the ideal distal landing zone in TEVAR for acute type B dissection. My intended learning objective is to show the importance of selecting which zone, importance of how to optimize this zone, and to discuss some of the clinical techniques that we use in my conclusion. So the basic fact, we all are using TEVAR, definitely much better than surgery, and it's now considered the first line of treatment of acute complicated aortic dissection. Residual flow in the false lumen is a marker of procedure failure. Once you get this, it means that you haven't done your job properly. Presence of chronic aortic septum and persistent false lumen is a major issue at the moment, and all the devices we have does not have anything to offer you to deal with distal landing zone. The goal of TEVAR is optimize the true lumen, maintain branch patency, and promote thrombosis of false lumen. This is what you're looking for to have a successful outcome. Common cause of failure, usually your distal landing zones, because the aorta is diseased, you have a little bit of gap. And this gap will make continuous filling retrograde to the false lumen. And that is why you have a persistent false lumen and you really haven't closed the dissection. And in this situation, you either do open aortic fenestration or distal debranching procedure. So this is the cases that we usually have. You always like to have normal aorta distal. We've always been trained in vascular surgery from normal to normal. In aortic dissection, you can't do that. Sometimes the patient does not offer you distal normal aorta. You have dissection until his iliac. So no normal aorta is available, and try to avoid aggressive overdilatation, obviously with aortic dissection, to avoid sign. And the understanding of distal anatomy landing zone is important. We all are dealing with aorta as one organ. Not look at proximal zone and distal zone. Look at it from the aortic valve until the iliac. It's one, and every effect of one part reflected on the other part. So the ideal landing zone, hopefully, we like to have it normal aorta, but this is very rare. Maybe you can have it in aneurysmal disease, but in dissection, you don't have a normal aorta, you have a dissected aorta. So how to optimize? During my cardiothoracic training, it was the same technique, which is called fenestration. So your main is to do fenestration to make this false lumen to be compressed and to have expansion. This can be easily done by open surgery, just nick it by the knife and do intimate retaining suture. But in endovascular, you still can do it. And this is a technique called DELZO technique, which has been known now for around 10 years for distal landing zone optimization. So how can endovascular you do what has been done by surgery? This is the basic idea. You have a dissection and you have sometime one single fenestration. You want to expand the urestent in order to push this flap to the aorta. So you try to retain the normal aorta consistency. Is that easy? It's not easy, but you have to do it this way. So the example, this is one of the cases that I have done TEVAR on, and believe me, aortic dissection cases, you need to follow them for the rest of their life and your life. They always come with a challenging problem, because this is a diseased aorta, and putting TEVAR will not make it normal aorta. So here you can see persistence of septum distal to TEVAR, and the area which false lumen which was closed started to open. Now, DELZO, easy technique. You go with the wire proximal and you go distal. You make sure, absolutely sure, you are in the true lumen, because if you have this mistake in the false lumen and you put anything there, it's a sudden death. There is no play around with this. So this is a basic DELZO technique. You actually just to go into the distal flap and you do fenestration, and then you expand your stent. And these are the steps of DELZO. Fenestration can be done with a septostomy knife, which is a technique I learned from cardiologists. And it can be done with laser fenestration if you have the option of laser devices in your unit. And you must have at least 3 to 4 fenestration to get enough enough amount of blood from the false lumen and to have a regain your lumen. I usually rely on two devices to know what is true and what is false. IVIS and endothoracic echocardiogram also can help me in knowing which flap to use. And I usually use two views. Very important to know which is the true lumen, which is the false lumen, and where is the septum exactly. And contrast field, there is so many techniques. I will concentrate on nice clinical tips, which I learned across the way for many years. If you don't know where is the false lumen, sometime you can put a guide wire to try to see where is the branches, and then you can inflate the balloon and have an IVIS, and you can hit it with the needle from the true lumen to the false lumen. Once you get the balloon rupture, this means that you already enter the false lumen. Usually use standard devices, which is the Chiba needle, and use Ushida transjugular liver access set. I don't recommend to use anything off-label or anything that you haven't used before, and you have use it as off-label. And this is the needles that we usually use to do the septum. Now, needle puncture, it's an easy done, but you have to be very, very meticulous to know exactly what you're puncturing, because the problem here is sudden death on table. It wouldn't regain if you put the needle in the wrong place at the wrong time. So I put a case here, which I have done. There is two videos. I tried to put you where is the false lumen. I went from the right leg of the patient with a cystectomy knife, and then you puncture the false lumen, the wire goes straight away, and after that you do ballooning to this fenestration, because you want it at least to be 5 to 6 millimeter to get it. So this is the balloon. Your first balloon, you start by 10 millimeter balloon, and after that you go up to maybe 20 millimeter balloon. So you want to enlarge it, and this has been done by endovascular. And you really, this is the critical step of this procedure. I always have two views. I have the device. I like to have IVIS with multiple views to know exactly where I am. You cannot allow it mistake in this stage of balloon septostomy. So aorta is one organ. Delzo is a standard technique for distal optimization of the distal landing zone. Obviously, bringing proximal landing zone to be optimized will help you, of course. This is one of the tricks that I've used across attending courses. Squeegee. Squeegee is a technique that if you have two fenestration, you pass a wire between the two fenestration and you try to enlarge them a bit. And this technique is called the squeegee. If you have the laser aortic septostomy set, definitely it's very good, because here you can select where you want your septostomy. Usually it is 1 centimeter distal to the TEVAR that you have put in, and you try to enlarge it to be 5 millimeter, but after you pass the wire, you can just balloon it. Now, this is a nice technique, but I couldn't do it at all, which is called a cheese wiring cutting technique. It basically is you pass a wire from the true lumen to false lumen, you hold the two parts in, and you try to pull it down, like as if you're cutting a cheesecake. I tried to do this. I spoke to people who have done this. I couldn't do it. But this is one of the techniques that's been used in some places. So commercially available TEVAR devices does not really address the distal landing zones. I hope you have a device with proximal configuration to cover all the arch and distal configuration to cover the distal landing zones. But we don't have. These are the 4 devices that we have: Valiant, Bentromic, Gore, and Zenith, and Rely by Trumo. None of them address the distal landing zone. So at the moment, we have to do it ourselves. We have to do the puncture ourselves, and we have to do the conclusion. I'm very sorry for taking a long time. My conclusion, very simple. We need devices that can address the distal landing zone, which we don't have. Distal optimization is very important, should be learned with the proper technique and proper tools. Septostomy puncture needs a lot of training and very meticulous technique, and thank you very much.
Thank you, Dr. Amar, for the excellent presentation.